He has a 4-day history of fever and increased thick yellow-green sputum production and diffuse muscular aches. During the past 2 years, he has produced 2 to 3 tablespoons of yellow sputum daily. He has smoked 2 packs of cigarettes for 30 years. He is 6 feet tall and 40 BMI is high. On admission, his temperature is high, pulse is high, respiration high, BP high, pulse oxygen is 60. On admission, an anterior posterior portable X-ray shows bilateral diffuse interstitial infiltrate. Without consolidation, he does not respond to high flow oxygen. He is intubated and mechanically ventilated. Exam shows hyperresonance to percussion and wheezes bilaterally. Ceftriaxone and levofloxacin are given and his symptoms improve. Hospital day 4, he is extubated. Temperature is fine. Pulse is it's 100. Respiration high. BP still high. Oxygen pulse oximetry while sitting shows an oxygen saturation of 95. His 6 hours later, the patient oxygen saturation goes down to 86. The patient is lying in bed and says he feels fine. Physical exam shows no wheezing or crackles. Oh, wrong guy. There is no peripheral edema. Repeat checks essays show improvement. Which of the following is the most appropriate next step in management to improve this patient oxygen saturation?
Okay. Intubation and mechanical ventilation are indicated in this patient who are apneic, hypoxic, or hypercapnic, not responding to less invasive means, are unable to protect their airways, lethargic, not lethargic, no gag or no cough reflex, lethargic, no gag or no cough reflex. After intubation and mechanical ventilation, patients may have component of respiratory insufficiency caused by prolonged dependence on a ventilator. Respiratory muscles can atrophy, leading to respiratory insufficiency. In this patient, hypoxia is not caused by pulmonary edema, infection, or chronic obstructive pulmonary disease exacerbation, and is likely caused by respiratory muscle atrophy after several days of intubation. Additionally, this patient has morbid obesity, which can cause respiratory insufficiency through mechanisms such as chest wall restriction when supine and suppression of the central respiratory drive. Exercise such as pulmonary physiotherapy, repositioning to a sitting or standing position, and coughing can improve oxygenation and respiratory muscle use.
24 female medical student sustains a deep laceration in her left index. Oh, what happened? Never mind. Medical student sustains a deep laceration in her left index finger while assisting the surgeon during an operation on a patient with cervical cancer. The surgical patient has a history of multiple sexual partners and IV drug use. It is not yet known if she is HIV positive. Exam of the medical student shows 2 centimeters bleeding laceration. The bleeding stops with compression. Which of the following is the most appropriate next step in management? Pending results of HIV testing on the surgical patient.
Okay. So occupational exposure to HIV is common in healthcare personnel as a result of needle stick injury. And other surgical injuries such as small laceration or punctures, the rate of seroconversion following accidental HIV exposure the rate of seroconversion following accidental HIV exposure is low, estimated approximately 0.25 to 0.35%. The risk of seroconversion the risk of seroconversion is dependent upon several factors, including the risk of seroconversion is dependent upon the several factors, including the patient's HIV viral load, the depth of injury, puncture with a hollow board as opposed to solid needle, or injury with a visibly contaminated instrument. Immediately following exposure, the area should be copiously washed with soap and water. Baseline serial serologic testing for HIV should be performed at the time of exposure up to 6 months following exposure. If unknown, the patient's HIV status should be determined immediately. Post-exposure prophylaxis should be instituted as soon as possible following unknown or possible exposure to HIV. A variety of the regimen are frequently employed. And commonly multi-drug antiretroviral, including two nucleoside reverse transcriptase inhibitors such as tenofovir and emtricitabine, and integrase inhibitors such as raltegravir or dolutegravir. All needle stick or surgical injuries should be reported promptly so appropriate testing and follow-up can be arranged. Okay, it is needle stick injury.
Here is not needle stick. Here is like a surgical, because it's not a needle. She just got laceration from the surgery. Like she actually got cut. It's not a
Okay,
needle. Hmm.
so if like needle stick or got cut, we start doing the antiretroviral
Yeah,
if
that's
if
what they
if,
say.
if the patient is HIV positive.
No, it says if you suspect that the patient may be exposed to HIV or if you know already that the patient is HIV. So even if you're suspecting, because here it says that the patient has multiple sexual partners, so in does IV drug use, so you're suspecting that he may be HIV. So you give art immediately.
Okay, we do not need the investigation and other things.
While you're doing the investigation, the patient test HIV testing is pending. So they are testing HIV for the patient, but while they're testing, you start giving prophylaxis to the person that got cut while you're waiting for the results.
Okay.
Next. 10-month-old female infant is brought to the office by her parents for a follow-up exam 3 weeks after undergoing stage repair. 3 weeks after undergoing stage repair of a left complete in unilateral cleft lip and palate. 3 weeks after. The procedure and recovery were uncomplicated, and the infant was discharged home like 2 days later. The parents report she's feeding well with the traditional bottle nipple and now also consumes some soft baby food. She has not had fever, pain, or nasal regurg. She receives no medications. Today, she's at the 25 percentile for length and weight. Vital signs are normal. A physical exam discloses a well-healing surgical incision on the left upper vermion and filtrum. The palate also appears to be healing well without wound the sense of palatal holes. The patient parents should be informed that she's at increased risk of which of the following.
Okay, so velopharyngeal insufficiency. It is like another T cell deficiency along with the DJOT syndrome. In the first state, it is written.
Mm.
Okay, velopharyngeal insufficiency. Cleft palate may occur in either complete or incomplete fashions and may occur unilaterally or bilaterally. Cleft lip occurs. Cleft lip occurs from a failure of fusion. Cleft lip occurs from a failure of the fusion of the maxillary and the nasal prominence. Cleft palate occurs from the failure of the fusion of the palatine prominence. Cleft lip and palate occur as an isolated developmental anomalies or in the setting of the chromosomal abnormalities. Patau syndrome or Smith-Hardin syndrome of mid-facial hypoplasia, Treacher Collins syndrome. Treatment requires surgical repair. Velopharyngeal insufficiency is a common sequelae of the cleft palate. With or without repair, velopharyngeal insufficiency is defined. Velopharyngeal insufficiency is defined as the inability to properly close the velopharyngeal port separating from the nasopharynx or oropharynx during the production of the speech, which is frequently caused by shortened palate or persistent palatal defect. Velopharyngeal insufficiency can lead to high-pitched hypernasal whistling speech, high-pitched hypernasal whistling speech reduced intelligibility, with reduced inte- intelligibility, persistent or severe velopharyngeal insufficiency require additional surgical repair. Okay,
Okay. Velopharyngeal.
so in velopharyngeal, what is the key point? Cleft lip, cleft palate, and
So it's
associated.
like
Sorry.
it's like at the back of the mouth. Okay. 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 Yeah, the key is just the palate, the palate. Even if you the cleft palate, even if you do surgery or don't do surgery, you can still get the velopharyngeal insufficiency.
Okay.
Hmm, interesting. Um, where is it?
Next,
Next, 22 men brought to the physician by his parents because he has become newly preoccupied with religion during the past year. He lives with his parents and attends a community college. 2 months ago, he stopped attending his classes. His parents report that he spent most of his day in his room alone reading religious scripture. He shows no interest in activities he once enjoyed, no longer spend time with friends, masturbates frequently and obviously, and spend most of the night walking around his room laughing and talking to himself. He has no history of serious illness, doesn't take medications, vital signs normal, physical exam normal, mental status exam. He has depressed mood and animated effect. His speech is pressure and responses to questions are tangential. He reports hearing a voice during the past 2 months that he believes is the voice of God. He says that he feels confused and has thoughts about ending his life because he cannot understand if God truly wants him to become the next Messiah. Which of the following is the diagnosis? Oh, Jesus. Mm,
what is your thought?
This schizophrenia, he has a lot of things going on.
Okay, schizophrenia is like more than 6 months, isn't it?
More than 6 months, yes.
So why it is not schizotypal? Schizotypal
Mm,
personality disorder may not be schizotypal, but there is another thing that like schizophreniform.
you're
It
right.
schizophreniform is like 1 to 6 months, within 1 to 6 months.
Mm-hmm.
So I don't understand. Like 2 months ago, he stopped attending his class, and
But see, it says that the thing started a year ago. That's one thing. And
okay,
then I don't think they will in this specific question. I don't think they will give you schizophrenia following schizophrenia both in the answer choices.
okay.
You know, yeah. Um, Read the explanation. Maybe the explanation will give us like a better why they choose.
Okay, according to DSM-5, patients with schizophrenia demonstrate at least two of the following five symptoms: delusion, hallucination, disorganized speech, disorganized behavior, and negative symptoms. Many patients also illustrate prodromal periods of strange behavior and social withdrawal. To meet diagnostic criteria, patient must demonstrate functional deficit, and the total duration of the symptoms must not exceed 6 months. This the cause is thought the cause is thought to include dopamine dysregulation, and brain imaging typically shows decreased cortical volume and enlarged ventricle. With The treatment of schizophrenia is antipsychotic, which can be divided into two groups, like typical haloperidol, flufenazine, and chlorpheniramine, and atypical like risperidone, quetiapine, and olanzapine.
Okay. So yeah, I guess they are considering that 1 year. It says the Prodomo period, so that 1 year of where he was like into religion. They consider that for the 6 months. Okay. Next.
Yes.
26 primigravida woman has spontaneous rupture of membranes at 30-week gestation. She's afebrile, no contractions. Sterile speculum exam shows a closed cervix and a pool of clear fluid in the vagina. Most likely complication.
Mm, oh, mm, Closed cervix and pool of clear fluid in the vagina. Okay. Preterm preterm rupture of the membrane refers to rupture of the amniotic sac before the onset of the labor. Regular contraction plus cervical change. If it occurs before 37 weeks of gestation, it is termed as preterm premature rupture of the membrane. Patients typically report a gush of fluid or steady leakage of fluid from the vagina. Initial evaluation includes a sterile speculum examination of the vagina, which may show pooling of amniotic fluid or leakage of fluid from the cervical os. Nitrogen testing of the fluid will show pH 7 to 7.3, and farning will show microscopy examination. And farning on microscopy examination, ultrasonography can also be utilized to determine ultrasound can also be deter ultrasonography can also be utilized to determine the amount of the residual amniotic fluid which would be decreased in the setting of the rupture of the membrane. Risk factor include previous premature rupture of the membrane, a vaginal or the cervical infection, and cigarette smoking. Patients with preterm pre-labor rupture of the membrane are at increased risk of preterm delivery, as the rupture of the membrane usually precipitates the onset of the labor. Thus, these patients are treated with betamethasone to accelerate fetal lung maturity, and fetal lung maturity. Antibiotics are commonly administered prophylactically as a result of increased risk of chorioamnionitis. The most likely complication of this patient being preterm pre-labor rupture of the membrane is preterm delivery.
Okay. Next. 8-year-old African American girl with sickle cell disease is brought to the physician by her mom because of 12-hour history of cough and difficulty breathing. Her medications are penicillin and folic acid. Temperature is high, pulse is high, respiration high, BP low, pulse oximetry, oxygen saturation is 94. Pulmonary exam crackles are heard in the upper lobes, breath sounds are decreased at the lung basis. The reminder of the exam is fine, X-ray of the chest is shown. Which of the following is the most appropriate next step in diagnosis? What do you see on the
What is the
X-ray?
diagnosis?
Oh no, what do you see on the chest
There
X-ray?
is fever, cough,
No,
breath sound are decreased at the lung base. Lung base.
what?
Crackles. Is it crackles are hard at the upper lobe.
Mm, don't know. A pneumonia? I don't know.
Pneumonia, sickle cell patient, sickle cell lung disease. Okay, maybe
Mm-hmm.
it's yes, acute chest syndrome.
Oh.
Okay, patients with sickle cell disease are increased risk for rapidly progressive patients with sickle cell disease are increased risk of rapidly progressive life-threatening infection as a result of hyposplenia and accompanying immunocompromise. Acute chest syndrome occurs as a result of vaso-occlusion within the pulmonary vasculature. Vaso-occlusion within the pulmonary vasculature is diagnosed in patients with sickle cell disease who present with new pulmonary infiltrate in the setting of fever or a new respiratory symptoms including cough, shortness of breath, increased work of breathing, tachypnea, hypoxemia. Acute chest syndrome is a leading cause of mortality in patients with sickle cell disease. While acute chest syndrome is a distinct clinical syndrome, it is commonly precipitated by another illness such as bacterial or viral pneumonia, asthma exacerbation with hypoventilation or fat emboli. Uh, patient plain farm X-ray typically shows segmental or subsegmental consolidation or a pleural effusion with the predilection for involvement of the lower lobes. It is both impractical and nearby impossible to distinguish acute chest syndrome from bacterial pneumonia in patients with sickle cell disease. In patients with sickle cell disease who present with fever or acute chest syndrome, obtaining blood culture is essential to promptly identify the bacteremia. Empiric antibiotics should be initiated immediately after the blood culture are obtained and should not be delayed pending for further workup. Further treatment involves analgesia, maintaining normoxia and supplemental oxygen, and the use of non-invasive positive pressure ventilation. Okay, okay.
Hey, oh,
Can you please explain?
oh, they're saying that because you cannot differentiate acute chest syndrome, which is like, I guess it's the way they describe it is kind of like a pulmonary embolism for sickle cell. Because
Okay,
they say that the vasculature or whatever, there is like a thrombi or whatever in the pulmonary vasculature. But it also comes with fever and chest pain and all that thing. Or, no, I mean, sorry, fever, cough, shortness of breath. So you cannot differentiate that from bacterial pneumonia. So when the sickle cell patient comes with those symptoms that you think is bacterial pneumonia, just take the blood culture first and then start giving antibiotic immediately while you're still checking if it's pneumonia or if it's acute chest syndrome. That as prophylaxis. You give antibiotic, you take the blood culture, and you give oxygen because he's having shortness of breath you know so that's kind of what they're saying.
okay. What you are
Mhm.
saying?
Huh?
Uh, what you were talking about? Next up. Another
Oh,
option we need.
yes, you could read B and D. Sorry.
Okay.
I guess B doesn't really make sense. Nah, don't read B. B doesn't really make sense. It reads D as in dog.
D for donkey suits better.
Yeah, default. Default donkey. Okay, donkey.
Okay. Spiral CT scan of the chest. Spiral CT scan of the chest is useful for identification of pulmonary spiral CT scan of the chest. That is the CTPA, isn't it? CT pulmonary angiogram, or is it another thing?
What did you say? I can't hear you.
Uh,
It cut
like
me.
CT pulmonary angiogram and spiral CT scan of the chest. Is this both are same or they are different?
No, I don't think it's the same. No, no, no. The spiral city is used for. It was something specific. We found a question about that. I don't
Why?
remember, but it's not
Why?
the same thing.
Where?
On UWord, there was a question where it was like, oh, for that specific, you use the spiral one. City. I just don't remember, but it's not the same as city angiogram.
Okay.
Let me Google it. But yeah, there was a question. Spiral city scan is used. Hmm. Hmm. Okay, I guess it was pulmonary embolism. Mm,
So we can do CTPA or spiral CT.
CT angiogram or spiral CT. Yeah, but usually it's CT angiogram.
Yes,
Usually.
CT pulmonary
Yeah.
angiogram, CTPA.
Yeah.
Okay, spiral CT is used for identification of the pulmonary embolism, which is often not evident on plain film X-ray while in adult with sickle cell disease are at increased risk for venous thromboembolism in the setting of the acute chest syndrome. This complication is less frequent in patient, and if there is concern, it can be assessed after blood culture are obtained. Okay. And
Mm.
E, thoracocentesis.
Oh no, it was just D.
Okay.
Okay, so if we think it's pneumonia, we have to do the blood culture, even if there is a possibility of PE or anything else. Okay.
In case of sickle cell disease,
In case of sickle, yeah, specifically in case of sickle cell disease. Yeah. 58 old men admitted to the hospital for treatment of anemia. 2 days ago, he had excessive blood loss following colon polyp removal via colonoscopy. Today, his hemoglobin concentration is low, hematocrit low. 2 months ago, in order to decrease transfusion errors, a blood lock system was implemented in which the patient ID must be entered in the lock to open the blood container. The container cannot be opened without the correct ID. Requiring staff to enter the patient's ID to open the blood lock is best described by which of the following?
okay, it's a forcing function. A forcing function is a design feature that prevents a desired action from occurring if a prerequisite action is not performed first. Reduced Forcing function reduce human error by anticipating mistakes that are likely to occur, requiring a verification step or other intermediary step to reduce the likelihood of such an error occurring. In this case, a common error in the blood transfusion involves transfusion of the incorrect blood type or blood product, or administration of a product to the wrong patient. The blood container forcing function verification of patient's identity before allowing the blood product to be removed, forcing healthcare staff to perform this verification Reduce the likelihood of transfusion error.
You read A and C.
An affordance, an affordance is defined by human factors engineering as functional potential of an individual or object within the environment. Within the healthcare, this term is often applied to design of a medical instrument to describe the way in which the instrument's design suggests or conveys how the instrument should be used. An interruption in care and a policy, an interruption in care or and a policy leading to delay in the care are incorrect, which offering functions delay in immediate administration of the care. That they do so deliberately in order to reduce the likelihood of the human error. The likelihood of the human error. Verification process maximize patient safety and num, reflect a normal part of administration of care rather than interruption or delay. I don't understand these two, the affordance and the interruption.
I if I'm don't quote me on that, but the way they describe affordance, it seems that it just says that what it's just an instrument and they tell you how the instrument is used. So they give you this, what is it, scapula or whatever, and they say there is a instruction on how to use it. Kind of, that's what affordance. That's how I understand the affordance, the way they explain it here.
Like
And
giving a catalog how to work.
how to use it. They give you the stethoscope and they say, okay, this is a stethoscope. This is how you use it. You put one in one ear, the other. You listen to the heart, blah blah blah. This is kind of how I understand it. I don't know if that's what it is, but yeah.
Okay. And
And
the
then
interruption.
I don't know. This is just like if they add something that I don't know. I don't know what that means. Seriously, I don't know. Maybe
So
something that is.
so the forcing function is easy. Like before blood transfusion, if you put an
Mm-hmm,
ID and if
mm-hmm,
you pressurize to see the ID, then there is less chance of ABO, like blood product, less chance
mm-hmm,
of
mm-hmm.
incompatibility, ABO
Yeah.
like transfusion problem, transfusion reaction.
Yes. Yes. Mhm.
Okay.
Next. 24 hours after admission to the hospital for treatment of high temperatures and abdominal pain, 22-year-old man has decreased has a decrease in his temperature. 24 hours. 2 weeks ago, he went on a 5-day trip to South America and had diarrhea for 7 days. He has no previous history of illness. On admission, CT scan of the abdomen shows like a 5 centimeter mass in the right lobe of the liver. The mass was filled with fluid. He has received metronidazole, ampicillin, gentamicin since admission. His current temperature is fine and blood pressure is fine. The abdomen is flat with moderate uh, right upper quadrant tenderness and garlic. There are no peritoneal signs. Serum titer for antibodies for entamoeba histolytica is 1 out of 128. Is positive at 1, I don't know. Which of the following is the most appropriate next step?
So infection with entamoeba histolytica leads to amoebiasis or amoebic dysentery. Entamoeba histolytica is an amoebic parasite that forms cysts, which can be transmitted through the fecal-oral route, typically through ingestion of contaminated, typically through ingestion of the contaminated water. Amoebic cysts mature to trophozoite in the large bowel, which may invade the colonic mucosa and interstitium, leading to symptoms of abdominal pain and bloody diarrhea, and may enter the bloodstream and cause hepatic amoebic abscess, which present with fever, right upper quadrant pain, The diagnosis can be made by identifying cysts mm, on stool, microscopy, or peripheral blood smear, which may show trophozoite with endosomes containing red blood cell, as well as antibody assay or polymerase chain reaction. Colonoscopy show mucosal ulcer that are often flask-shaped. Treatment of hepatic amoebic abscess involves combination therapy with metronidazole or tinidazole, as well as antiluminal agents such as paromomycin or idoquinoline in this otherwise stable patient with a confirmed diagnosis. It is most appropriate to discontinue broad-spectrum antibiotic with ampicillin and gentamicin.
Can you read all the other options?
Okay, continuing current antibiotic regimen for 10 days is unnecessary. In general, uncomplicated amoebic liver abscess can be treated with. How we understand this is uncomplicated. Uncomplicated amoebic liver abscess can be treated with amoebicidal agents alone. Amoebicidal agents is paromomycin, metronidazole. These are the drugs, isn't it?
Mm-hmm. Mm-hmm.
Tinidazole.
Mm-hmm.
So, performing examination of the stool for ova and the parasite is useful method of diagnosing amoebiosis, but is unnecessary for this patient in whom the diagnosis has already been confirmed with serum antibody assay. Okay, performing CT scan, guided aspiration or surgical drainage of the mass is unnecessary given this patient's improvement with conservative management. Surgical drainage surgical drainage may be necessary for large abscess greater than 5 centimeter in diameter and abscesses in the left lobe of the liver, which is associated with increased risk of peritoneal rupture, or patients who fail to respond to antibiotic therapy. Uh, okay.
Mm-hmm. Previously healthy 23-year-old woman brought to the ED 20 minutes after the sudden onset of shortness of breath, moderate abdominal pain, nausea, and itchy rash over the abdomen. Her symptoms began after she ate a sugar cookie given to her by her friend. The patient had a peanut allergy as a child, and before eating the cookie, she asked her friend to taste it. Neither she nor her friend tasted or smelled peanuts. The patient only medication is OCPs. Her last menstrual period was a week ago. She has smoked a pack of cigarettes for 5 years. She drinks on the weekends. She has been staying at different friends' homes during the past 2 months while searching for an apartment and has been using unfamiliar laundry detergent. She is in my respiratory distress, but is able to speak in full sentence. Pulse is high, respiration high, BP low, pulse oximetry. Oxygen is 94. Photograph of the rash is shown. Scatter wheezes are heard bilaterally. Cardiac exam is fine. Abdominal exam shows diffuse tenderness to palpation. Which of the following is the most appropriate pharmacotherapy?
What is your diagnosis?
Anaphylaxis.
So epinephrine then, but
Yes.
just looking at the abdomen, it is very tough to find out the anaphylaxis
Mm-hmm.
because there is no bigger swelling in here. Okay, you want me to read the explanation?
Yes, please.
Okay. An anaphylactic reaction is an hypersensitive. An anaphylactic reaction is an hypersensitivity reaction to an exogenous factor, most commonly medications, food, insect stings. Most commonly, medications, food, insect stings. It is mediated by activation of the IgE, which leads to it is mediated by activation of the IgE, which leads to release of the histamine, which leads to release of the histamine and other cytokines from the mast cell or basophils. This subsequently leads to acute inflammation and profound vasodilation in the multiple organs. Profound vasodilation in the multiple organs, generally the cardiovascular, respiratory, gastrointestinal, integumentary system. Symptoms include rapid onset bronchospasm with dyspnea or wheezing, urticaria, flushing, nausea, and emesis. Edematous lips and tongues, and administration of the epinephrine, antihistamine, bronchodilator, glucocorticoid, as well as IV fluid. Severe cases may require endotracheal intubation and the administration of the vasopressor. This patient with a history of peanut allergy consumed cookie that likely contained traces of peanuts, leading to an anaphylactic reaction of dyspnea, abdominal pain, nausea, urticaria, wheezing. Therefore, the most appropriate treatment is epinephrine, as it treats the underlying mechanism leading to manifestation of the anaphylaxis. Epinephrine causes vasoconstriction, bronchodilation, and decreased cytokine release. Delay to epinephrine administration increase the risk of death.
Okay. Next. 67 man comes to the physician because he has noticed blood in his urine for the past 2 weeks. He has no prior history of blood in the urine. He has not had pain or any other symptoms. He has hypertension controlled with diuretic and hypercholesterolemia controlled with statin. His blood pressure is fine. Exam shows no abnormality or analysis shows RBCs that are too numerous to count. Which of the following is the most appropriate next step in diagnosis?
Okay, so it's bladder cancer. Okay, bladder cancer can be diagnosed by in urine analysis. There is plenty of RBC. Is there anything else in the stem
Mm-mm,
apart from the RBC?
mm-mm.
Okay, so bladder cancer is the most common malignant tumor of the urinary tract, a majority of which is transitional cell carcinoma. Risk factors include chronic cyclophosphamide, schistosomiasis, chronic cyclophosphamide, aniline dye exposure, and tobacco smoking. Tobacco smoking. Patient usually present with painless gross hematuria. Diagnosis is confirmed by cystoscopy, and the diagnosis is confirmed by cystoscopy and biopsy. Usually, flexible cystoscopy is done. Flexible cystoscopy with biopsy is done, which is the most sensitive approach for identification of small mucosal tumor.
Mhm.
Transitional cell carcinoma in situ refers to lesion of precursor malignant cell that are conformed to the epithelial lining of the bladder and have not yet invaded the subepithelial connective tissue or muscle. Treatment requires resection of the cells with negative resection of the cells with negative margin, which can be achieved through cystoscopic resection. Okay.
Okay, next. 57, man comes to the ED because of 3 week history of headaches that have been increasing in severity and frequency. 3 weeks. He also has 2 week history of progressive blurred vision in both eyes. He has not had pain in the eyes. Last visit to physician was 10 years ago because of pain in his fingers. At that visit, he was told he had high blood pressure. Temperature is fine. Pulse fine. Respiration fine. BP super high. Repeat BP super high. Yeah. Findings on fundoscopic exam are shown. Exam shows ulnar deviation of both hands and several swollen interphalangeal joints. His fasting glucose is high. Which of the following is the most likely cause of the most likely underlying cause of the patient's symptoms?
Okay. It is due to hypertension. Okay, hypertensive retinopathy results from chronically hypertensive retinopathy result from um,
Beginning.
hypertensive retinopathy result from chronically increased blood pressure with subsequent microvasculopathy of the retinal arterial vasculature. Patients often report generalized blurry, although may be asymptomatic, and may also report associated symptoms such as headache, chest pain. Typical fundoscopic findings include constricted retinal arteriole, retinal hemorrhage, nerve fiber layer infarction, hard exudate, lobular choroidal infarction. The retinal hemorrhage typically occur in the inner retina and adopt a linear configuration to be distinguished from from distinguished from the round hemorrhage that occur in the middle retinal layer in the setting of diabetic retinopathy. Retinal edema and hard exudate typically conform to the radial orientation of the nerve fiber with respect to the fovea. Retinal characteristics: macular star appearance, optic disc edema and hemorrhage, and obscuring the disc margin mimicking papilledema. This patient's presentation finding and including retinal hemorrhage, nerve fiber infarction, hard exudate, macular star configuration, bilateral optic disc edema, characteristics severe hypertensive retinopathy. Patients with hypertensive crisis and evidence of end organ damage should be managed emergently for appropriate blood pressure control. Okay.
Can you read A, B, and E? Yeah. A, B.
Yes, so diabetes mellitus can cause diabetic retinopathy, which is caused by retinal hemorrhage, hard exudate retinal nerve fiber layers, and the presence of linear retinal hemorrhages or and bilateral optic disc edema is not consistent with diabetic retinopathy. Is not consistent with diabetic retinopathy. Glioblastoma multiforme is an aggressive primary brain astrocytoma that carries a poor prognosis. Patients present with seizure, headache, focal neurological deficit, while papilledema may be suggestive of intracranial pressure in the setting of central nervous system lesion. The patient's linear retinal hemorrhage, hard exudate, nerve fiber layer infarction suggests that his optic disc edema is caused by hypertension and therefore does not represent papilledema. Okay.
Okay. Oh, E. Sorry, rheumatoid arthritis.
In hypertensive retinopathy, like,
No,
sorry,
rheumatoid arthritis. The E, choice E.
rheumatoid arthritis commonly produces finding with the anterior segment of the eye, such as dry eye, episcleritis, and corneal ulceration. Usually in hypertensive retinopathy,
Mm-hmm.
we remember there is a grading called sac puppy,
Okay.
hypertensive retinopathy grading, silver wiring. You say you have written linear retinal hem. Oh, you are
Can you say the sad puppy? I heard sad puppy, but I didn't know it was
sac
for
puppy, silver wiring, arteriovenous nicking, cottonwool spot, and papilloedema.
wait. How you sad puppy?
Like, you find the grading hypertensive retinopathy grading, then I am making you understand.
On in a circle.
You can find in the Google too,
Do I just put hypertensive retinopathy?
pathy grading. Yes.
Hypertensive retinopathy grading. Okay.
Yes, there is like grade 1 is silver wiring. Go to the box. The
Right
box.
here.
Yes,
What?
yes,
Mm-hmm.
yes. In here, they have not this box. The lower one.
Or I just put sad puppy.
Sac
Oh, not like this.
SAC, then puppy.
Sack puppy. Okay, no, it doesn't come out. Never mind.
Okay, remember this, like silver wiring, artery
Mm-hmm.
venous nicking, cottonwool
Okay.
spot, and puppy for papilloedema. That's the thing. That is the mnemonic.
So that's to remember what you see on the.
Yes, on the ophthalmoscope finding, on the fundoscopic finding, there is silver wiring, there is artery venous nicking is usually seen on ophthalmo. If you do ophthalmoscopy, you can see the artery venous nicking.
And then what's the C?
Sorry,
The C. The C. Sack.
cottonwool spot.
Spot. And then the puppy is the papilledema.
Yes.
Got it. I wanted to see the difference between what they kept saying the difference between the linear retinal that you see and the round retinal hemorrhage that you see in diabetic retinopathy. See it? I don't think you can see it really.
These ophthalmoscopic things are very complicated. In
Yeah,
uh, it may be understand on this picture, but in the reality, you are unable to focus. That's the tough.
that yeah.
So
Usually you can figure it out from the question.
yes, we can
Usually.
figure it out from the question, but in the reality, it is very tough because lots of people cannot tolerate uh, that light, and we need to see for a
Mhm.
long time. Like, we need to see for 3 to 5 minutes to make the diagnosis.
Oh.
So For that long time, the people do not tolerate.
Okay.
It is easily done in case of like ICU patient, like comatose patient, because
Mhm.
their findings are easy. But in case of other like normal people in diabetes or in hypertension, these findings are very hard, very tough to find it out. Okay,
Okay. Okay. I cannot I see it, so it's fine. Okay. Then we can stop here today.
okay.
Okay. I'll see